Consider a patient simultaneously facing active cytotoxic chemotherapy while managing type 2 diabetes and non-alcoholic fatty liver disease. Type 2 diabetes, or T2DM, is a chronic condition characterized by cellular insulin resistance and persistently elevated blood sugar. Non-alcoholic fatty liver disease, or NAFLD, is the pathological accumulation of lipid droplets within hepatic tissue. Operating on this specific physiological baseline creates a systemic metabolic crisis. The patient is subjected to hyperinsulinemia, acting as a constant accelerant for malignant cellular activity. Hyperinsulinemia is a condition where excess insulin circulates in the blood, often driving unchecked tissue growth. Alongside this elevated insulin, the patient has an abundance of circulating glucose. This oversupply provides an unrestricted fuel source, directly supplying the substrates required for rapid tumoral biomass accumulation. To process this fuel, the tumor relies on a metabolic mechanism known as the Warburg effect, or aerobic glycolysis. Aerobic glycolysis is the cellular fermentation of glucose into energy, even when adequate oxygen is available to the cell. Malignant cells upregulate specialized membrane proteins like GLUT1 and GLUT3, constantly pulling in glucose from the bloodstream. Once inside, the cell rapidly converts this imported glucose into lactate. The tumor maintains this specific biochemical conversion regardless of local oxygen availability, bypassing standard mitochondrial respiration. This rapid conversion produces a massive volume of acidic byproducts, requiring immediate lactate efflux. The tumor prevents its own internal acidification by pumping the lactate out of the cell via MCT4 transporters into the extracellular matrix. MCT4 transporters are specialized cellular export channels dedicated to clearing lactic acid. The patient's systemic metabolic dysfunction does not passively coexist alongside the cancer. The elevated glucose and insulin actively arm and accelerate the tumor's primary bioenergetic supply chain. Moving past the cell membrane, we examine the resulting conditions in the surrounding tissue space. The tumor microenvironment, or TME, is the complex local ecosystem of blood vessels, immune cells, and signaling molecules directly surrounding a malignancy. The constant efflux of lactic acid from the tumor cell severely drops the pH of this microenvironment, holding it at a highly acidic 6.0 to 6.5. This severe drop in pH directly inhibits the proliferation and cytotoxic activity of CD8+ T cells. CD8+ T cells are specialized immune agents responsible for identifying and destroying malignant cells. The acidic saturation also manipulates another key immune population residing in the microenvironment, tumor-associated macrophages, or TAMs. TAMs are white blood cells that normally engulf dead cells and coordinate immune responses, but they are highly sensitive to local pH. The lactate-rich environment forces a functional polarization of these TAMs, shifting them into the pro-tumoral M2 phenotype. The M2 phenotype is an immunosuppressive state where macrophages actively repair tissue and suppress inflammation. Once locked into this M2 state, these macrophages actively promote tumor growth, assist in local tissue invasion, and drive angiogenesis. Angiogenesis is the biological formation of new blood vessels, which tumors co-opt to secure their own blood supply. To optimize the efficacy of cytotoxic chemotherapy, we must actively collapse this metabolic supply chain at its source. We must systematically dismantle this acidic TME, treating it as a highly engineered immunosuppressive defense mechanism. The care team should treat the ketogenic diet as a targeted pharmacological intervention, a deliberate metabolic therapy used to starve the malignancy. By utilizing the ketogenic diet, we systematically restrict the circulating carbohydrates required to fuel aerobic glycolysis. The 2020 meta-analysis by UN and colleagues quantifies the specific level of glycemic control achievable in patients with T2DM using this intervention. This chart shows aggregated data on glycemic control. Fasting blood glucose decreased by an average of 1.29 millimoles per liter. Concurrently, glycated hemoglobin, or HbA1c, reduced by 1.07%, a standard biomarker reflecting average blood sugar over 3 months. Shifting our focus from the bloodstream to hepatic tissue, we look to the 2024 findings by Dynka and colleagues regarding liver pathology. The ketogenic diet actively suppresses hepatic de novo lipogenesis. De novo lipogenesis is the biological process where the liver converts excess dietary carbohydrates into stored fatty acids. Halting this process allows for the rapid clearance of intrahepatic lipid droplets, driving a fast resolution of NAFLD parameters and reducing liver stiffness. Resolving NAFLD is a strict clinical prerequisite. Clearing the liver of excess fat restores the optimal hepatic cytochromal function that is absolutely mandatory for processing and metabolizing chemotherapeutic agents. The second pillar of this protocol implements a 16 to 8 intermittent time-restricted eating window, or I-tray. I-tray is a dietary schedule that confines all caloric intake to an 8-hour period, followed by 16 hours of continuous fasting. In a healthy cell, nutrient scarcity immediately downregulates the mTOR pathway, an intracellular cascade driving rapid cellular growth. Concurrently, the cell upregulates AMPK, an energy-sensing enzyme that triggers strict maintenance, conservation, and recycling mechanisms when ATP drops. This adaptation is differential stress resistance, or DSR, where healthy cells enter a highly protected state during starvation. However, malignant cells lack this metabolic flexibility. Their oncogenic growth pathways remain jammed in the on position, preventing adaptation to nutrient scarcity. We can observe this mechanism functioning in human in vivo models, validated by the 2025 Ben Salem clinical trial. Over a 6-month period, researchers measured physiological autophagic flux in human subjects undergoing an I-tray protocol. Autophagic flux is the specific rate at which a cell degrades and recycles its own internal waste components. The subjects demonstrated a statistically significant increase in LC3b2 degradation, measured directly within peripheral blood mononuclear cells. Peripheral blood mononuclear cells are circulating immune cells with a single round nucleus, and LC3b2 is the SATE protein marker indicating active autophasome formation. Differential stress resistance functionally widens the therapeutic index, allowing us to hit vulnerable, proliferating cancer cells while selectively shielding healthy, dormant tissue from cytotoxic chemotherapy. Implementing aggressive dietary restriction in an oncology setting requires strict management of systemic cachexia. Cachexia is a complex metabolic syndrome characterized by the severe, involuntary loss of skeletal muscle and fat tissue. This muscle wasting is heavily driven by the feudal Cori cycle, an anatomical loop where the liver constantly converts tumor-derived lactate back into glucose to refuel the tumor. Running this conversion costs the host massive amounts of ATP, acting as a severe, relentless energy drain. To counter this, we position tetrahydrocannabinol, or THC, as a highly strategic clinical antiemetic within the protocol. We utilize THC's well-documented physiological effects to stimulate patient appetite specifically for dietary lipids and proteins. This maintains the patient's caloric baseline entirely without feeding the tumor exogenous glucose. Concurrently, we enforce absolute adherence to aggressive hydration protocols. Pushing high volumes of fluid is necessary to clear acidic metabolic byproducts and protect renal function while the patient processes chemotherapy in a ketogenic state. Finally, we utilize light postprandial skeletal muscle contraction to maintain a glycemic sink. Postprandial refers to the period immediately following the consumption of a meal. Muscle contraction triggers the translocation of GLUT4 transporters. These channels migrate to the cell surface, pulling glucose from the blood and clearing residual serum glucose. Together, these adjunct therapies prevent the metabolic protocol from inducing cachexia or nephrotoxicity. We keep the patient physically stable while ensuring the tumor starves. For the multidisciplinary care team, understand that executing this protocol rapidly and violently destabilizes the patient's prior pharmacological baseline. We mandate that the oncology team continuously track serum LDH levels throughout the entire intervention. Serum LDH stands for lactate dehydrogenase, an intracellular enzyme released into the blood when cells are rapidly consuming glucose or experiencing damage. Based on the 2015 findings by Petrelli and colleagues, we establish LDH as a critical, validated prognostic biomarker for survival. Tracking these LDH levels provides the team with precise, real-time data indicating the exact rate of the tumor's current glycolytic activity. Because it maps directly to lactate production, LDH acts as a direct, measurable reflection of the tumor microenvironment's hostility and total acidity. Deploying adjunctive metabolic therapy requires the exact same real-time biomarker vigilance as the administration of the cytotoxic agents themselves. Finally, we issue a strict safety briefing to the endocrinology team regarding aggressive medication titration. Maintaining the patient's prior type 2 diabetes pharmaceutical regimen while their insulin sensitivity rapidly rebounds is highly dangerous. We explicitly mandate the immediate downward titration or complete cessation of SGLT2 inhibitors. SGLT2 inhibitors are a class of oral diabetes medications that lower blood sugar by forcing the kidneys to excrete excess glucose into the urine. Combining SGLT2 inhibitors with a deliberate ketogenic state creates a severe risk of inducing euglycemic ketoacidosis. Euglycemic ketoacidosis is a life-threatening medical emergency where the blood becomes dangerously acidic despite blood sugar levels appearing deceptively normal. You must also aggressively titrate down any administration of exogenous insulin. Similar immediate reductions must be applied to any prescribed insulin secretagogues. Insulin secretagogues are oral medications that artificially force the pancreas to release more of its own stored insulin. If these specific drugs remain active while the patient is fasting and producing extremely low endogenous glucose, they face an acute risk of severe hypoglycemia. Hypoglycemia is a condition where blood sugar drops well below the healthy range, rapidly leading to seizures or loss of consciousness. By synthesizing extreme metabolic restriction with precise, proactive pharmacology, the clinical team can safely dismantle the Warburg effect. We cut the tumor's supply chain, shield healthy tissue through stress resistance, and achieve maximum cytotoxic efficacy.